All right, we are going to continue into our next plenary talk. I have the privilege of introducing Dr. Doug Powell, who really truly does not need an introduction. For those very few of you who may have not had a chance to hear him speak, he is an amazing instructor and teacher. He has taught so many of us in this room and is an amazing clinician. And of course, again, I think really no further introduction is necessary, but the bio is several pages and obviously very well deserved. Uh, as far as pulling up Dr. Powell's slides, do we have them? Okay. Thank you. All right. Without further ado, Dr. Powell.
Thank you all, and it's a real pleasure to be here among so many people that have so much respect for and just all you're doing in taking care of our folks. But I want to start by thanking Chris Knight so much for his service and just being an incredible governor and just leading this chapter. So this is a geriatrics talk, and the reason I became so interested in it is twofold. One, I started at DW in 1989. I still had patients from my internship in 1985, and of course, quite old, just as I am. So the combination of myself getting older and all my patients getting older, having a lot of issues that come up when you take care of people that are older. And I'm going to try to go through cases where I hope you can use the app and answer what you think, and then try to highlight things that are newer, and then some things that I've just noticed over the years, and then went back into the literature to look to see if common sense things make sense. And the answer is usually yes. So here's our first case. An 80-year-old man with hypertension, COPD, atrial fibrillation presents with severe chest pain and is diagnosed with an NSTEMI. He was found to have a 90% LAD occlusion, receives a drug-eluting stent. Current meds are apixaban, tiotropium, amlodipine, and lisinopril. What therapy should he receive? Apixaban, clopidogrel, clopidogrel, and aspirin, apixaban, and aspirin. So if you can enter that in, I don't know how this is going to show up on here. Pop up. Okay, I'm not sure if we're going to get everybody's response, but so the bottom line on this is we don't want to give triple therapy to people anymore. And really, aspirin has got some issues, and there's some very recent literature we'll cover there. So this person is going to stay on their apixaban, and then you're going to add clopidogrel. Let's go ahead and give you some numbers of what's been going on with all this, and it is quite scary. This is very old data with a lot of these folks were on warfarin therapy, but looking at triple therapy had bleeding risk over 1 year of 44.4% compared to 19.4% in the individuals who didn't get triple therapy. So I think it's an important thing to always put into the equation what is a bleeding risk, and it's so much bigger issue the older the patient gets, because GI bleeding in a 90-year-old is usually a fatal event. It's very difficult. Things start to snowball there. They can't move for a while. They're in the hospital for a while. So triple therapy is really out. Looking at dual platelet therapy versus triple platelet therapy in stent patients, again, more data. Dual therapy, 2.4% bleeding. Triple therapy, 58% of these patients were on a DOAC, 42% were on warfarin, but pulling them together, 18%. So such a dramatic difference between dual and triple therapy. This was a very important study that was published in the New England Journal in 2019, where they actually looked at patients who were on anticoagulants, assigned patients with AFib, with acute coronary syndrome and undergone the PCI, and we're going to be taking drugs after their stent placement to get apixaban or warfarin and to receive aspirin or a placebo. So they were all going to get their probably mostly clopidogrel at that point, plus their anticoagulant, and then they gave half of them placebo, half of them aspirin. And what happened? Not surprisingly, individuals who got aspirin bled more, but more importantly, there really wasn't a difference in outcome as far as cardiovascular issues. So this was very important and should have been the beginning of the end of triple therapy, but it hasn't been. This is a study that we all have to think about, which is the idea of how long do we keep people on antiplatelet therapy after a stent. And there's been so many articles out there about this, and we see anywhere from 1 month to indefinite. And frequently our cardiology colleagues will say, well, I'm about this person because they have such bad coronary anatomy, and I'm always worried about everything. So I just want to keep them on it forever. And what does the data show? This study from 2019, I think, was done. Patients were randomized to either 1 month of dual antiplatelet therapy followed by clopidogrel monotherapy, or 12 months of dual antiplatelet therapy with aspirin and clopidogrel. Younger patients, average age is 66, so these are not our very elderly that we hear the most about. 1 month dual antiplatelet therapy was non-inferior and superior to 12-month dual antiplatelet therapy for primary endpoint, occurring in 2.3% with the 1 month and 3.7% with the 12-month. Not surprisingly, the bleeding endpoint occurred less in the patients who did not get long-term dual antiplatelet therapy. So less bleeding, non-inferior. This is a study that just came out a few weeks ago, which again, same theme. We bleed a lot when we give more anticoagulants, and the older the patient, the more catastrophic. This was a double-blind, randomized, placebo-controlled trial, previous stent implantation over 6 months before enrollment, and we're at high vascular risk and currently receiving long-term anticoagulation because of mostly AFib. Patients were randomly assigned 1-to-1 to receive aspirin or placebo, and then they got their anticoagulant they came in on. The trial was stopped early. The primary efficacy outcome event occurred in 16.9% in the aspirin group, 12% in the placebo group. So it actually, the placebo group did non-inferior, actually with a good p-value, they did better than the group getting aspirin, and not surprisingly, a lot more bleeding in the aspirin group, 10.2% to 3.4%. So how do we take all this stuff and look at our very old patients, our patients that are 85 to 105, that group? We have to go a lot on faith in this group because many of these people are not enrolled in the standard studies we look at. The studies generally don't look at 90, 95-year-olds. And so we don't know what to do with them. But you can be pretty sure it's not going to be less of a bleeding risk than we see in the populations that get studied. And as I mentioned earlier, a GI bleed in a 95-year-old, 90-year-old is generally catastrophic, that these patients do not bounce back like our 60-year-olds who have a GI bleed. So being very, very cautious with them. So what's the safest approach? Really no triple therapy at all. And really trying to decrease the amount of anticoagulants with the new study, not having people on both aspirin and an anticoagulant for atherosclerotic risks or prior MIs. You got them on an anticoagulant, their outcome's going to be good. And then keeping the antiplatelet therapy for as short a course as possible. An 84-year-old woman with diabetes presents for follow-up. She feels well. She has a history of hip replacement 4 years ago and will be having dental cleaning next week. She had labs done yesterday, which showed hemoglobin of 13, a crit of 39, white count of 8, UA of 30 to 50 white cells per high power field, A1C of 7.3. What do you recommend for her? 2 grams of amoxicillin 2 hours before a dental cleaning, 2 grams of amoxicillin 2 hours before and 4 hours after. Amoxicillin clavulinate for 1 week to cover both tooth cleaning and treat the UTI, or no antibiotics.
submit button is all the way at the bottom.
So it will show up if people vote. We'll keep our fingers crossed. If not, Chris can fix anything technical and. Well, we'll see. Well, I know this crowd is gonna all put the right answer, which is, anybody want to volunteer? No antibiotics, that's right. Well, we certainly don't want to treat the asymptomatic bacteria here. We know that she's gonna have that, so we don't want to treat that. And all of you get badgered by dentists and orthopedic surgeons to prescribe antibiotics for people that have joint replacements. And we're going to go through that. And just say no. I mean, it's insanity. It's absolute insanity. It's kind of like the government. You know? It's like you go, why? Anyway, this is the 2024 AAOS clinical practice guideline. Which uses systemic prophylactic antibiotic prior to dental procedure in patients with hip or knee replacement may or may not reduce the risk of subsequent periprosthetic joint infection. Okay, so that is in patients, that's using antibiotics prior to a dental procedure. So they're basically saying, the group that is asking us to do it is saying, we don't know if it's helpful. Well, the answer is we know it's not helpful. So this is a beautiful study out of Taiwan back in 2017, 255,000 individuals who underwent total knee or hip arthroplasty between January 1, 1997 and November 30th, 2009, 57,000 patients who underwent dental treatment matched with equal numbers who did not. 6,500 matched pairs of patients who underwent dental treatment were further matched with those receiving antibiotics and those who didn't. So we did a nice job of matching everybody and looking at the antibiotic folks, the non-antibiotic folks, the people who had dental procedures, people who didn't. And prosthetic joint infection occurred in 0.5% in the dental sub-cohort and in 0.61% in the non-dental. So dental cleanings didn't seem to be associated with it. And there was no difference in infection risk with those who took antibiotics and those who didn't. Which makes total sense, right? Because we don't tend to see mouth organisms in prosthetic joint infections. When we do have the rare patient who gets it, it's not a mouth organism. So that never made any sense. So I got really interested in this a bunch of years ago. One of my patients, 84-year-old, basically this patient, who got put on amoxicillin by the dentist, actually gave her amoxicillin prescription, and I told her not to do it, and like, oh, they want me to do it. And she got horrendous C. diff. And she ended up going to fecal microbiota transplant to try to control it. So it's not a trivial thing. It may seem a single dose or a couple of doses, but alter your life. So just to give you an idea of what happens to our older individuals when they get Clostridium difficile, this population-based cohort study of individuals 65 and older, patients with C. diff in general older in this cohort with an age of 81. Hospitalization was much higher in this group. Antibiotics in the prior 90 days obviously were more common in the C. diff. C. diff infection led to doubling of both mortality and total healthcare costs. So we have a lot of tough decisions to make on when we give antibiotics, and I think we use a lot of judgment, but this one is just stupid. This one, if anybody gets C. diff out of this, it's just dumb because we're not protecting them from anything. So, I think it's good to just push back and say, no, I don't think you should be on it. I reach out to the dentists, orthopedic surgeons, I send them something, I wrote about it, and, I send them the guidelines. And hopefully over time, this will go away. Lots of C. diff cases, potentially 240,000 patients with C. diff infection, 46,000 deaths, $6 billion in costs. An 86-year-old man with Parkinson's disease and heart failure has a ground level fall, striking his head, and is brought to the ED. He has a CT scan of the head and neck that shows no fractures, but shows a thyroid with several greater than 1 centimeter nodules. 6 months ago, he had a TSH of 1.5. He was referred to his primary care physician for follow-up. What do you recommend for evaluation? Has anybody seen this before? We had this, I had 2 in 2 weeks. Thyroid ultrasound, repeat CT in 6 months, or no workup. I don't think our app has given us stuff, right? We haven't had anything pop up yet. Okay. So how many people like thyroid ultrasound? How about CT in 6 months? Oh, here we go. So looks like we're pretty close to 50-50 between thyroid ultrasound and no workup. And I think I would go with a no workup here. Thyroid ultrasound's generally benign unless you act on them. Then all hell can break loose, right? I mean, it's like that, 86-year-old guy, Parkinson's disease, heart failure, just had a fall. His 1 year mortality is probably about 50% when you put in all those factors into it, including his fall. So why are we going to chase this? So let's go through some of the stuff. So we know in 2017, this Preventive Task Force, when it used to be in function, concluded with moderate certainty that screening for thyroid cancer in asymptomatic individuals results in harms that outweigh the benefits. So that was old, feeling the thyroid, doing some kind of, physical exam screening, but there was a concern about this, and the benefit is going to just escalate the older our patients get. The other thing is, as we get thyroid nodules, over 55% of patients over 70 had thyroid nodules. If you look at the very elderly, 100 years, 75% had thyroid nodules, and those nodules tend to be bigger too. If you look at the natural history, though, of these, most nodules are benign. Even in the small percent do have thyroid cancer. The older the patient, the presence of comorbid conditions make likelihood of dying from thyroid cancer extremely low because patients die of other causes. And as you know, in general, the majority of thyroid cancers are papillary with a 20 to 30-year history. And certainly when you have a 94-year-old or an 80-year-old with Parkinson's disease heart failure, you're not looking at a 30-year history. Even the road cancers, the anaplastics, the worst ones, it's a real question of intervening is going to make a difference there. So I'm not saying that you can't have an 85-year-old who you find a nodule and it could turn out to be something bad, but it's more likely that pursuing that nodule, ending up operating on that, all those things are going to be a much higher risk, especially in your patients with comorbid conditions. So I have adopted pretty much the policy that when I get CT scans that tell me they're thyroid nodules in my patients 85 and older, I leave it alone. I do shared decision making. I say, my shared decision making is don't do it. And they go, okay. Very few of my older patients are like, I want to do that medical stuff, And if they push back and they really want to do it, we'll meet with the family, we'll discuss it, and we'll make a decision together. But that almost never happens. A 72-year-old man with a history of MI 4 years ago presents with right hip pain. He's had discomfort with walking for the past 6 months. X-ray reveals moderate OA. Most recent labs, B1 of 6, creatinine of 0.8, glucose of 100. What would be the most appropriate pain management plan? So we got somebody with a history of an MI 4 years ago, hip pain, moderate OA, renal functions just fine. What's the most appropriate management plan? Acetaminophen, oxycodone, ibuprofen, diclofenac, or celecoxib? Great, everybody's putting him on acetaminophen. You're not scared off that he's going to get autism at 72, huh? He's very good. And I know you're going to say, I'll do that, but now you tell me what's actually going to work for him. When he calls 2 days later and goes, acetaminophen didn't work. That's not what we're going to talk about. So yeah, I think that's the safest option here, but I think some of you who have hung around me know my disdain for NSAIDs as people get older, and especially in the very old. And I just wanted to go through some of the data on MI risk and heart failure risk with NSAID use, because I don't think that's gotten as much publicity. We all know about GI upset, bleeding. We all know about renal issues, but the cardiac issues are important too. This is a nice study from Denmark. Let's see. There we go. A great study from Denmark. We get a lot of really good studies from Denmark because they have a really good closed pharmacology system where every prescription can be tracked, so you can do really good research there. Study with 99,000 patients, average age of 69. They looked at pharmacy records and medical records for everybody over the age of 30 with a first-time admission for MI. And then they looked at NSAID use and what happened to these people. Hazard ratio for death with NSAID use was 1.59 at 1 year, 1.63 at 5 years. Recurrent MI was 1.3 at 1 year, 1.4 at 1 at 5 years. Not numbers that scare me, right? And this is, if the risk is on the low side, 1.5 times the risk isn't huge. It's just being aware of that. The FDA did put a warning about this back in, I think it was around 2015, to educate all of us that there is a possible increased risk of MI with NSAID use in people who have had previous MI. Much more likely, though, is triggering hospitalization for heart failure. This is a study, 365 cases of patients admitted for heart failure compared to 658 control patients without heart failure. NSAID users had an odds ratio of 2.1. Odds ratio went up to 10.5 for first admit for heart failure if the patient had heart disease and used NSAIDs. And the risk for admission was higher with a longer-acting NSAID. So individuals who were using drugs like piloxicam with a long half-life had a lot more problems because they didn't really get a break from it. This is a very recent article that just brought this to light again. And again, higher risk patients taking NSAIDs are more likely to show up with heart failure. So another Danish study looking at patients with type 2 diabetes and the link with NSAIDs, 331,000 patients with type 2 diabetes, 23,000 were hospitalized with heart failure. 16% of the patients claimed at least one NSAID prescription within a year. Short-term use of NSAIDs associated with increased risk of heart failure hospitalization, especially in those over age 80. Again, higher cardiovascular risk, probably have subclinical heart failure that's getting brought out to be clinical heart failure with the NSAID. A lot of times people thought, well, COX-2 might be safer. They seem to be, in some studies, a little safer on the gut. How do they perform for the heart? And just spoiler alert, they're not any better. So not really any statistical significance cardiovascular outcomes between fluxocoxib, naproxen, and really ibuprofen. If you look at the number of problems that occur with NSAIDs in the GI tract, very, very, very high. This is a study many years ago, 25 years ago, published in the New England Journal, estimating 103,000 hospitalizations annually in the United States for GI complications of NSAIDs at a cost in $1999 of $2 billion and 15th leading cause of death in the United States. SSRIs can increase the risk of GI bleeding when added to NSAIDs. Multiple studies have shown that, and just being aware of that issue. American Geriatric Society guidelines for pain management really put a damper on NSAID use. NSAIDs should be considered very rarely and with extreme caution. So all of us are going to use NSAIDs from time to time in our geriatric populations, but weighing it like any other really important decision and looking at the major risks versus the benefits. If you must use NSAIDs in the elderly, this is short acting for as short a time possible. Ibuprofen at 200 to 400 milligrams a couple of times a day is certainly safer than 800 milligrams 3 times a day. COX-2 inhibitors, slightly less GI bleeding risk, but the same cardiovascular renal risks. And if they have no choice but to be on them chronically, the decision of whether a PPI should be added. PPIs certainly have their long list of issues, but they certainly have been proven to be protective against ulcer disease with NSAIDs. A 94-year-old man with advanced heart failure presents with a new growth on his right cheek. A shaved biopsy reveals nodular basal cell carcinoma. The lesion is 1 centimeter in diameter, non-ulcerated and asymptomatic. What is the most appropriate management? Wide local excision with 1 centimeter margins under general anesthesia, micrographic surgery, electrodesiccation and curettage in the office, topical Lemicor cream for 6 weeks, or observation. So the right answers here, I think, are E and C. I think those are probably the two best choices. This is a 94-year-old guy with heart failure. Can his survival, if you plug it into the calculator, probably 1 year to 18 months, maybe. And so most, which is sort of the standard we do with something like this in most of our patients, but in our very elderly, it's a lot. It's a lot for the patient and the family to get them there. It's going to be some healing issues, not really indicated. And so electrodesiccation and curettage is something that will work and can be done in the office. You could also look at potentially cryotherapy if you just want to beat it down for a little bit, or you can be observation and see if this thing is going to grow at any rate that's going to actually impact this guy, and the likelihood of that is extremely unlikely. When you look at treatment of basal cell carcinoma in patients over 90, survival was 40 months for people under the age of 93 years, 28 months for those over 93 years. So you're thinking, on average, your average population this age, a couple of years after 93, what interventions are going to be useful for their life and for their quality of life? More conservative treatment options, including watchful waiting, are appropriate in patients over 93 and in patients with dementia. If you look at some of the less invasive options, curettage versus cryosurgery for superficial basal cells, 1-year clinical clearance rate, 95% for curettage, 100% for cryosurgery. This is a little bit dependent on what the actual path shows, on whether it's a nodular basal cell or not. But again, fairly simple things if the patient, family want a treatment, things we could do in our office. A 76-year-old man with type 2 diabetes, coronary disease, and chronic kidney disease presents for Medicare wellness exam. He's received pneumococcal vaccines, shingles vaccine 2 years ago, and got a Tdap 3 years ago. He received influenza vaccine in the fall. His last colonoscopy, where he had no polyps, was 10 years ago. What do you recommend for him? Tdap, a PSA, and colonoscopy, or no testing or immunizations this visit? Okay, great. So most of you are choosing no testing immunizations. I'd agree with that. He had a clean colonoscopy 10 years ago. He's 76 years old. He's got coronary disease, chronic kidney disease, enough things that the colonoscopy may be problematic. And we're going to go through some of the evidence on that. This is a study looking at effectiveness of screening colonoscopies in this age group, 70 to 79. 1.3 million Medicare patients, 70 to 79, average risk for colorectal cancer with no previous colonoscopy in 5 years. That would fit this guy. This is a guy who had a clean colonoscopy 10 years ago. So we feel his risk at worst would be average. Age 70 to 74, 8-year risk for colorectal cancer, 2.19% for the screen, 2.62 for the non-screen group. The number needed to screen, 283. When you get older, 75 to 79, like this guy, colorectal cancer, 2.84 in the screen group, 2.97 in the unscreened group, and the number needed to screen now is 714. Now, if you look at the number needed to harm, that's much, much lower. So the younger crowd, the number needed to harm was 179. The older crowd, the number needed to harm was 97. So here's that number needed to treat, much higher than the number needed to harm here, helps us guide our decision. This is a study looking at the estimated life expectancy with colonoscopy findings and follow-up recommendation among older adults. A cohort with data from the New Hampshire Colonoscopy Registry of individuals 65 and older underwent colonoscopy surveillance after having known polyps in the past over a 10-year period. 8% of the patients in the study had advanced polyps, with 0.2% of the patients having colorectal cancer. 86% received a recommendation for future colonoscopy. In patients with a life expectancy less than 5 years, 58% received recommendations to return for future colonoscopy. So our GI folks are going to ask them to come back. It's our job to tell them not to. You know, there's a point where it makes no sense, and we really want to protect them from that, because people look at guidelines, they look at a polyp every 5 years, and that may never stop. So what do we do? We want to personalize the risk assessment. The age of the patient, 75, is what the U.S. Government Task Force, the AGO, looks at, not screening beyond that, except for special circumstances, individuals who had high-risk colonoscopies and have a projected significant life expectancy beyond that. The screening history is really important. People who've always had negative colonoscopies, probably after age 70, don't need to continue on with that. Family history was factored in, but most importantly, beyond age is comorbidities. So this patient was over 75, so that would be not recommended for screening. Colonoscopies put him at average to lower risk, and he had 3 comorbid conditions. There are some other reasons that we are so worried about the harm we can cause by colonoscopy as our patients get older. Patients that are older often are not as quick to get up and be able to move around. The perforation risk goes up over the age of 80. But over 80 have a much higher perforation risk than a 50-year-old. Fall risk with bowel prep. I've had that happen a couple of times. I felt horrible. You know, like, why was I having this more frail person get a colonoscopy? And then they were trying to get to the bathroom because nobody wants to poop themselves, you know, so they're scrambling to the bathroom, fall and break their hip. That has a huge mortality risk. And then, of course, humiliation with the fecal incontinence that can happen with the prep. So all of these things need to be factored in. An 85-year-old man with type 2 diabetes and hypertension comes to clinic for follow-up. He's currently on metformin 500 BID, atorvastatin 20 a day, and aspirin 81 milligrams a day. He has felt more depressed recently and is concerned about his memory. He was also very worried about heart disease. His blood pressure is 130/80, his pulse is 80. So 85-year-old guy, typical couple diseases, hypertension and diabetes, on a few meds, really depressed, really worried about his memory, and he's really worried about his heart. What would you recommend for him? Increase his aspirin to 325, bump his atorvastatin to 40, check a vitamin B12 level, or recommend he walk 7,000 steps a day? Okay, well, we're still not testing the other guy. That's good. Okay, great. So we're gonna have this guy do some walking. Absolutely. If he can, and if he can't go 7,000, if he's doing 1,000, I want him doing 3. If he's doing 3, I want him doing 5. We don't gotta get crazy and tell him maybe 10,000 steps a day. But there is data on these things, and the data is remarkably shocking. This is a study, a cohort of men in Oslo screened for cardiovascular disease in 1972 and again in 2000. So a nice study that looked at many, many years and the impact of physical activity. Among almost 15,000 men born 1923 to 32 and participating in the original cohort, 5,738 participants were seen in 2000. 30 minutes of physical activity per day, 6 days a week, was associated with a 40% mortality risk reduction. There was a 5-year increased lifetime when comparing sedentary and moderate to vigorous physically active men. Increase in physical activity was as beneficial as smoking cessation in reducing mortality. That is striking. That is amazing. I mean, we don't want to get everybody to quit smoking, but being sedentary can limit life just about as much. All of you have seen many, 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 whoops. There we go. Thank you. So we've seen a lot of these studies that talk about how many steps, and they do vary, but they sort of end up similar. They're usually within 2,000 or 3,000 steps for the bottom line. And this study looked at number of steps per day with premature all-cause mortality. It was a good sample, a nice sample of different populations. Daily step volumes classified as low, under 7,000 steps, moderate, 7,000 to 10,000, and high, over 10,000. And looking at this, the bottom line was, compared to individuals who did under 7,000 steps, significant lower risk of mortality in the moderate group with hazard ratio of 0.28 and the high group 0.45. So it's not about you got to do 20,000 steps. It's just get as many steps as you can. If you can get over 7,000, that's great. But again, 5,000 in more recent studies is a whole lot better than 2,000. So just the bottom take-home point is physical activity is as important as smoking cessation in elderly patients. What else does physical activity and exercise help with in the elderly? Decrease depression and depressive symptoms, better sleep. All older patients want to talk to us about that. That's something we can help with. And then potentially decreasing the slope of cognitive impairment. An 80-year-old man comes to clinic for medical advice. He's been very healthy with no chronic medical problems other than osteoarthritis. He has good vision and his hearing is intact. Normal fasting glucose and blood pressure. He was a non-smoker, drinks 5 glasses of wine a week. Most impactful advice in regards to his mortality. Order colonoscopy and a PSA, check lipids and renal function, get him a pneumococcal vaccine, advise not to use ladders. Yeah. I get really ticked about the Medicare wellness exam because there's very few useful things on it. And I think it's good to do cognitive screening. I think it's good, but we really tell all the patients not to get on ladders. And I learned this my second year in practice. I had a guy who was 96 years old, no medical problems, zero. He was walking about 7 miles a day. I go, this guy's going to live to be 110. And he's going to be on the Today Show, and they're going to go, who's your doctor? And I'm going to get all the credit, right? And so he died, and I died because he fell off his roof. I did not tell him not to go on his roof. So I've made it a thing since then. Like no step stools, no ladders, 65. That's why you have friends. That's why you have grandchildren. That's why you have a bank account to hire people. You can have somebody younger get on the ladder for you because it's very, very deadly. When you look at causes of death in the U.S., the top ones we know, but unintentional injuries and falls, of all the things we can get that we don't address, that's the one. Now, here's some really interesting stuff. This is the fall risk based on age off ladders. Now, first of all, men are more likely to fall off ladders than women. And I have some thoughts on why. We'll talk about that in just a second, but you'll see that at younger ages, you see like 15, 29, 30, you see this inflection point. Really people get to be in their 40s, the rate goes up, and then you see 60, it just keeps going up, and hopefully nobody will know about the 70-year-olds because they shouldn't be on ladders. So this is just such a risk. And how many of you have had somebody have a catastrophic ladder fall? Yeah, and I've seen, and again, the most scary thing was about when my dad was 94. I walked in his house, I couldn't find him. He was up at the top of the stairs on a chair trying to change a light bulb, and he was fully anticoagulated. It's like, what are you doing? He's like, well, I could do it. So, increasing age was associated with worse falls. That's not surprising. So decrease in mean fall height, but an increase in mean injury. That's not surprising. We don't bounce as well when we get older. And these folks got more traumatic brain injuries, bad truncal injuries, and they were less likely to be able to protect themselves and get hand and arm fractures. They got the bad fractures. But here's why I think the most contributing thing, this is why I think these are all bad studies. 27 had severe trauma, and most important pre-fall factor is lack of accurate assessment of fall risk. I can do it. And you know, the bottom line is all of us think we're 30 years old in our mind. You said it about 30. So those of you who are 30 or younger, that's where you're going to sort of think of that. And then when you get to my age or you get older, you still sort of think that. And so your ability to make judgment on can I get up and down a ladder safely? I also remind them that's why it's called an accident. Yeah, I know you're safe with doing it, but things happen and you're gonna have bad stuff happening. So in summary, in general, develop very elderly, less is more. Not sending people for procedures that they don't need, not sending for surgeries they don't need, not sending for CTs they don't need, yet not putting them on 3 drugs when 1 drug can be just as good. Keep them moving and please keep them off ladders. Thank you.